Thank you. This is Dr. Daniel Lenihan. I'm the Director of Cardio-Oncology Center of Excellence at Washington University in St. Louis. And I have the great pleasure of speaking at the VCOS meeting. And my portion of the presentation is cardiac MRI and cardio-oncology, strain at its best fidelity. In our last Global Cardio-Oncology Summit in Brazil, we identified 10 priorities, and this was published in JACC Cardio-Oncology earlier this year. The 10 priorities are listed here, but I've highlighted two of the biggest ones that are certainly important, and that would include defining robust predictors of cardiotoxicity and clarifying the role of cardioprotection. Now, it's interesting that as we also had an ESMO guideline that was published this year in 2020, which had a complete overview of the management of cardiac disease in cancer patients throughout oncologic treatment. This was a very comprehensive and detailed document. And it's when you look at that document, it's got a lot of very important recommendations in there. But this one highlights the growing interest in strain as a measurement of a marker for cardiotoxicity or cardiomyopathy that's developing before a change in LVEF. So recommendation 5.3 from this document highlighted that in patients with a normal left ventricular ejection fraction, but having a decrease in average global longitudinal strain from a baseline assessment, you could consider initiating cardioprotective treatments such as an ACE inhibitor or an ARB. Also, to follow these strain measurements every 3 months and as a process of monitoring for cardiotoxicity. But we couldn't come out very strong in terms of what action points there are in regards to strain. So the final bullet there, that life-saving chemotherapy should not be altered solely based on changes in left ventricular strain, is just an acknowledgement that we didn't know as much as we should. If we look at the detection of cardiotoxicity, this figure highlights where we would like to detect a problem such that we could improve upon it. So if you imagine an assessment of contractile function or left ventricular function in a patient is normal, as they undergo the initiation of cancer therapy, there may be some decrement in their cardiac function. But if we identify that very early, we can institute cardioprotective medications to return it to a baseline value, and that's the green line here. As it turns out, in the current day, we do not see a significant change in left ventricular ejection fraction until it gets to a pretty profound level. And most of the time, patients are symptomatic at that point. This portion of the line is represented in red. And if you were to identify it at the point that there's significant systolic dysfunction, it's not as responsive to intervention. So the key is to detect the toxicity early and to institute cardioprotective medications in a place where the patient will respond best to that and hopefully normalize their cardiac function. Here's an example from a cardiac MRI-based study utilizing strain. Included in this is the Myotrain tool to measure regional strain abnormalities. So as you can see in this example, this patient at baseline had a normal left ventricular ejection fraction and had only very few abnormalities in regional strain. After doxorubicin-based chemotherapy, you can see there's a substantial drop in the percent of normal segments, and those are represented in this figure as yellow or green as opposed to blue, which is normal. And then the patient was given ramipril, which was an appropriate cardioprotective medication. And you can see the percent of normal segments improved. And over the course of time, with ramipril as a cardioprotectant, the patient was actually able to receive subsequent doses of doxorubicin with an actual improvement in their percent normal regional strain segments. And if you look at the left ventricular ejection fraction throughout the case, there really was no substantial change, although the left ventricular ejection fraction approached abnormal in the midpoint. So again, the whole point here is that if we look at the percent of normal myostrain segments, as the percentage goes down, the presentation of heart failure is more likely. So in the figure, that normal segments are blue, and then as they become more dysfunctional, they approach red. And so the key here is to detect the regional strain abnormalities prior to them becoming permanently dysfunctional. There a recently completed prefect study, which was performed primarily in Germany, showed that the percent normal myocardial segments through Myotrain technology could actually predict those patients who are going to develop cardiotoxicity. Thus, an important tool in our identified priorities within the International Cardio-Oncology Society. So for example, those patients that had a normal myostrain value of 83%, you can see here that the picture is almost a solid blue. They did not develop cardiotoxicity. However, those patients that had a significantly reduced normal myostrain percentage with different colors noted besides blue in the regional measurements, those patients were ultimately more likely to develop toxicity. And then during cancer therapy, as in the prefect study, you could detect changes from a baseline in patients that were developing toxicity. Their percent of normal segments persistently dropped. And you can see in this case here where the normal myostrain percentage of 45% documented significant evidence of strain abnormalities that indicated early toxicity. In order to test this hypothesis that myostrain was an essential component of MRI measurement tools, we have designed a study called PROACT, which is the proactive evaluation of function to avoid cardiotoxicity. I won't go through all the details of this study, but it is a prospective multi-center open label randomized study performed primarily at WashU. We are trying to robustly quantify myocardial function in patients undergoing anti-cancer therapy, and we want to determine the ability of myostrain to detect subclinical cardiac dysfunction. This is the study calendar, which is highlighted here. You have baseline assessment, 1 month, 3 months, 6 months, 12 months, and yearly thereafter. Here's an example of a patient who had a long history of metastatic neuroendocrine cancer and had multiple cardiac risk factors. And her baseline myostrain was 46%, which was significantly reduced. But if you looked at the left ventricular ejection fraction, you can see that it is clearly in the normal range. As the patient was continuing to receive active cancer therapy, and at baseline she had NYHA class 2 symptoms, she underwent optimization of her heart failure therapy, and the Myotrain value improved over time. So despite ongoing chemotherapy, the actual strain values improved. And if you look at the left ventricular ejection fraction, it remained in the normal range throughout. So in this case, the lessons are that patient can continue on aggressive chemotherapy despite abnormalities in strain, especially if you're monitoring it closely. And then optimal heart failure management was confirmed by the serial testing. The case number 2, again, highlights that this was a 36-year-old woman who had metastatic breast cancer, and she had been treated with combination HER2-based therapy. She also had multiple cardiac risk factors. And over the course of her treatment, at baseline, you can see she had a normal LVEF, clearly. However, her Myotrain values were significantly abnormal. And as she was titrated on optimal cardioprotective therapy, her Myotrain values improved, and then ultimately at the end, after 1 year, improved substantially. And if you look at the LVEF measurements throughout, at no point in time would you have said that she had evidence of cardiotoxicity. So the important point from case number 2 is that a patient can continue on aggressive anti-HER2 based therapy for over a year without worsening of her cardiac function. And the only issue here is that she did develop angioedema with ACE inhibitor, so her heart failure management was limited by adverse events. However, her symptoms improved and exercise tolerance normalized. In the last case we're going to look at this morning, this was a 63-year-old female with a history of lymphoma that had been treated with anthracycline, and in the middle of her anthracycline-based therapy, she had a baseline LVEF, which you can see here was reduced, and her Myotrain was markedly abnormal at 32%. Over the course of the next few months, she had substantial improvement in her Myotrain as her heart failure therapy was optimized, and you can see her LVEF normalized. However, right before her yearly scan, she had a drop, or at her yearly scan, she dropped her Myotrain value, and you can see that her LVEF also was diminished slightly. As it turns out, she had had an episode of pneumonia and had had total knee replacement, and in addition had been taking non-steroidals over the last 2 months prior to that scan. So Myotrain was able to detect a change in her optimal medical therapy and a subsequent stressor from pneumonia by a reduction in the regional Myotrain values. So the lessons from case 3 is the patient had cardiac dysfunction at baseline and during anthracycline-based chemotherapy, but with careful heart failure management, we confirmed the improvement in strain and LVEF, and then a sequential stressor had a detectable change in cardiac function. So these examples of general principles to refine clinical decisions with Myotrain results indicate that early identification of worsening segmental abnormalities can identify ways to enhance cardioprotective therapies. In addition, you would be able to advise oncology about developing toxicities. Further, you can enhance patient education and symptom awareness. And then lastly, by showing an improvement in left ventricular strain, regional strain abnormalities, you can encourage regular exercise with positive feedback. Thank you. This is my team at the Washington University in St. Louis. Thank you for your time.